if you can get your patients to cluck. If no one can cluck, I have patients that can't cluck and I'm like, oh Lord, they are not stable. They don't even know how to suck. And that light suction is what creates that little suction cup at night. So you're passively holding your tongue. Can the person breathe through their nose? Ask them, how do they sleep? Do they snore? Do they have headaches that just won't go away? Those are signs that they have an issue, but you look here and you'll learn a lot.
Welcome to APTA Orthopedics Podcast, where we help you stay ahead in orthopedic physical therapy. I'm your host, Luciano Garcia, and today I'll be talking with Jennifer Hobson on physical therapy, airway treatments, posture, breath, and swallow dynamics. Don't forget to subscribe for future episodes. Let's get started. Well, hello, Jennifer. You want to tell
Hi,
us a little bit
Luciano.
about yourself?
I sure will. So I'm Jenny Hobson from Chicago, and I am a physical therapist that has been specializing in the head and neck. A lot of people know me because I've been training with Mariano Rocabado in Chile since 2004. So my whole practice is based on head and neck dysfunction. So I see a lot of TMJ, tinnitus, dizziness, concussion, now snoring and sleep apnea and breathing dysfunction. So it wasn't until my kids got sick with tonsils and adenoids that had to be removed that I started getting curious about breathing. And so that's what I wanted to bring to the PT world, because we just don't learn this stuff. I've been going to different conferences, ENT conferences, sleep conferences, SLP conferences, myofunctional therapy conferences. So if you didn't know what myofunctional therapy is, that's a whole field of medicine that exists, and it's all about breathing and swallowing and oral posture. And I had no idea about it and became one in 2013. So really, this is a little bit about me trying to catch up the PT world around the throat and the airway and what compensations happen when there's a constriction or a narrowed airway.
Very nice. Is this related to or a subset of diaphragmatic breathing?
Absolutely. So what we want is our nose to work and our diaphragms to work. And so if we do that, we have nice, movement in the rib cage. The rib cage doesn't get stiff and it doesn't elevate. But majority of people have issues with their nose and they start to mouth breathe. So all the accessory muscles, and you too, the accessory muscles get really tight. The sternocleidomastoid, the scalenes, well, they elevate the rib cage, and then you have a diaphragm that doesn't really work anymore. The diaphragm should be working like this as you inhale and you exhale.
Going downward, yep.
Yes, but if you have an elevated rib cage, it no longer moves like this, it moves like this. So it's very little movement. So the diaphragm tends to not work properly, and then the neck muscles pull up the rib cage and get you into an inflated, inhalated position, and then a chronic neck tightness. So yes, it has a lot to do with, we want to restore rib cage mobility, nasal breathing, diaphragmatic activation. All of that is very important, but there's a hidden piece that people don't know about right underneath their throat.
Very nice. Can this training improve the need for a CPAP machine?
Absolutely. So what I've learned through my training with Mariano Rocabado, I understand the head and neck and its connection to the mandible. That's really important, but many people clench. Maybe you clench, maybe you snore. Many people do this, and it happens to be the work of two ENTs, the research of two ENTs. Wilfried Engelke from Germany has been studying the soft palate for years, and he's developed a little device that trains the suction. There's a little suction that's created with the back of the tongue and the soft palate. So if you close your mouth and swallow gently, you should feel the throat and the soft palate and the tongue meet. You create a little suction, and you can actually measure it with this device called the up blocker. So that up blocker, there's a perfect minus 15 millibar sweet spot of negative vacuum suction. It's very light that can maintain the tongue in the proper position during the day and night. It's like a little suction cup for your throat. And when you do it, it eliminates snoring and clenching. So it's something that I've added to my breathing retraining program, and I'm now teaching it through the Intro to Airway Evaluation Treatment course. It's a course that really will bring you up to speed with the research that's out there for airway dysfunction and really getting the PTs back into this field, because how many people have tight necks? How many people have craned necks? Their necks crane because their airway's trying to open, but the tongue drops down and their throats aren't stable and they end up clenching. So we need to look at it globally. We have to understand from the top to the bottom how it affects our spine and our posture, our swallow pattern, and our breathing pattern.
If someone has a long-term history of mouth breathing, can they significantly improve within their course of physical therapy?
I tell everybody it takes about 1 full year to retrain your breathing. And I'm serious about that. It's not an easy thing.
Yeah.
Mouth breathers tend to have a parted lips like this, like that. So you can't really tell they're mouth breathing, but they're sucking air through their mouth. And the hole in the back of your throat is so much bigger than the little nostrils that we have in our nose. So the problem is when your mouth opens up, it brings in 3 times the volume. So you're dealing with more volume than your nose can handle. That's why the nose kind of shuts down. It gets stuffy. People have a deviated septum because their growth and development pattern was with a mouth open, tongue down posture. Your tongue actually grows your mid-face and your nose. And if you don't use your nose, it bends and you have a high vaulted palate. So yes, it does work for mouth breathers. I was a mouth breather myself, a tongue-tied mouth breather, and ended up taking about a year to retrain it. But I was yawning and sighing all the time, feeling cold and tired. So those are symptoms. Some people have headaches, some people have neck pain. Some people have dizziness. So there's a host of different symptoms that occur when you start breathing improperly, and you end up breathing instead of 30,000 times a day, 60,000 times a day. I have some people even more than that because they don't realize how rapid they're breathing and how big volume they're breathing.
Mm-hmm. Let me ask you this, Jennifer. With this treatment approach, how is manual therapy incorporated?
So, I'm a true manual therapist. I got my MTC through the University of St. Augustine. So I'm very much into touching people and making things change, or teaching them how to stabilize. The rib cage, I use a lot of PRI techniques to kind of lower the rib cage. That is feeling the rib cage as you inhale. Try this if you'd like. Inhale gently through your nose with your tongue in light suction. Pause at the top. Now with your hands, I'm going to lower this just a little bit. I'm holding here. Pause at the top and grunt a little. Go. And you pull in your abdominals, your pelvic floor. You pull that rib cage down with your obliques. So the problem a lot of times with mouth breathers is they're breathing with their necks and chests all day. And so that's tension all day, and it doesn't go away. You put them on the table and their necks are on, but their head's supported. So that's the problem, is you need the rib cage to move. Then the neck, you know how the neck gets. If you treat any necks, the upper cervical spine is very, very limited in mobility. They don't have good movement in their OA, AA joints. And so you have to use your hands to manually move those joints and get them out of that stiffness that they have. You want to restore the curves of the spine. That's the lordotic curve of the neck. If it's not there, you're going to have tension forever. So manual techniques are definitely needed. We do a lot to the TMJ intraorally. We do a lot of soft tissue work, dry needling. All those techniques still apply. But these patients are not getting treated properly because no one's checking their airway. So if you open up your mouth and you look down your throat, can you see the hole in the back of your throat? And if you can't, you have an airway dysfunction, and you need the support of your tongue to train to get you back to a normal function.
Let's talk about sleeping postures. How does airway dysfunction relate to certain sleeping positions?
Yeah, so sleep is everything, right? If we don't get good sleep, we do not function the next day well, and we can't be prepared for work. So, for myself, I do a lot of training for sleep. I teach people to not lie on their back because their throats are, their mouth will prop open because of gravity in the mandible. The tongue will start following the mandible because it's attached. So you don't want that. You want to create, I always use a little Starbucks stick. If you create a little suction, so if I put a little stick under my tongue with a little suction, and I try to get my patients to, I call it boring face, get the most relaxed face with that light suction. That's what's going to start changing your breathing, your airway, your snoring, and your clenching.
Mm-hmm.
So side sleeping is important. I use a lot of pillows to support, and you don't want to crane your neck. When you crane your neck, you lose that contact with your soft palate and your tongue. So there's a lot of light suction exercises, light gentle breathing exercises to slow down the breathing to make it light so it's not heavy. So all my sleep apneics and snorers breathe 3 times the volume, so they're breathing heavy in and out. So it's a lot of reduced volume breathing training that I learned through Buteyko breathing method.
Mm-hmm. How about any research on this topic?
Yeah, I was mentioning, so there's 2 ENTs that I'm following. Dr. Wilfred Engelke, he is the ENT from Germany that designed, he's been studying the soft palate for years. He's designed many little devices to create a suction so that you can measure it. Measuring is everything. We need to make sure that we can measure things, and that light suction, he's done all the research back from 1870s that
Wow.
the dentist back in Germany had done this research that the light suction that's required to stabilize the airway is a minus 15 millibar of negative vacuum suction. So you can put a little manometer in that little device and measure them as they walk, as they move around, so that they're maintaining that stable airway. So he's one, and then Peter Catalano has done a lot of research on the nose. He's an ENT in Boston that really wanted to see why were people bruxing? Bruxing is clenching and grinding. He had 25 children and 25 adults. Those 2 groups were basically vetted by their dentist and their parents or the partner, saying that they were grinding at night and there was wear and tear on the teeth. Well, the only treatment was surgery. So nasal septum surgery, turbinate reduction surgery. So out of all the children that were treated, 100% stopped bruxing. For the adults, 25% stopped bruxing, 50% reduced, but 25% didn't change. And the fact of the matter is, our faces change when we don't breathe right from infancy to adulthood. We end up getting a bent nose, a deviated septum, and a high narrow palate. Sometimes we have a tongue tie. But these are things that I'm teaching through the Intro to Airway course because PTs don't know about it, and it's affecting the majority of people that you know. So I'm hoping to get this message out to the PT world because we see neck patients, we see spine patients. They're all having issues with posture of their neck, and many of them have airway compromise, including yourself maybe.
Mhm. How can this approach make us better clinicians?
You know what? I think I think it's really important to understand the TMJ and how it connects to the spine because there's many PTs that don't know that. So I teach that as well. But the airway part, I didn't know it. I was a TMJ, specialist for years and years. And I didn't realize the tongue had anything to do with it or that the tongue created a stability of the airway. So if you could learn how to identify when someone has, look at their nose. Is their nose bent? Is it narrow? Is it small? Is their nostrils one big, one large? When you look in their throat, look down their throat. Can you see a hole or do you see a wall of soft palate? Those are signs of a long-standing airway dysfunction. So once you can identify them, even if you don't do the work, you can refer them to the right practitioners. Right now, I'm trying to get PTs involved. Anyone that's dealing with head and neck, anyone that's dealing with spine should learn this. It's not that difficult, but you need to learn how to identify these patients. And there's many. There's many. The majority of neck patients are airway patients.
Hmm. So, Jennifer, in general, what are some clinical applications of airway dysfunction that an orthopedic clinician can use on Monday morning?
Yeah. So, first of all, I would like if everyone looked down their throats and saw their airway. Like it can use it. Put your phone on. Put the look at yourself
Mhm.
in the mirror in the video, and can you see down your throat? If not, there's an issue. If you can get your patients to cluck. If no one can cluck, I have patients that can't cluck, and I'm like, oh Lord, they are not stable. Don't even know how to suck, and that light suction is what creates that little suction cup at night. So you're passively holding your tongue, not active. So that's the key: is can the person suck and create a suction? Can the person breathe through their nose? Ask them. How do they sleep? Do you see that they're clenching? Do you see that their neck is craned? Those are airway compensations. Are they cold? Do they snore? Do they have headaches that just won't go away? Those are signs that they have an issue, but you look here and you'll learn a lot. When you see the back of their teeth, is there a bunch of metal? Is there a bunch of dental work? Is their mouth really narrow? Are their teeth crooked? Crooked teeth means airway dysfunction. Your tongue and your throat are not working together, and you grew with a you're growing into a constricted airway, and that's the problem. We need to treat the kids especially
Hmm.
because they're still growing.
Correct. If listeners remember only one thing from today's conversation, Jennifer, what do you hope it is?
I think one thing, I think we're capable of really taking this specialty in our toolbox. I think we are equipped to treat the whole body. We know how the whole body connects. There's lots of speech therapists and registered dental hygienists are in this field, but they have no idea how to connect the neck to the spine. So we are the ones equipped for it. We need to learn this. So we also have to learn how important the nose is. The nose is the health of your body. If your nose doesn't work, you're going to end up snoring and clenching and developing sleep apnea eventually. That's what happens. So I'm really urging PTs to really listen, consider taking the Intro to Airway course that I teach through the HobsonInstitute.com. I think it would be a really important piece of information in the grand scheme of things. You all know a lot already. You're fabulous in the orthopedic PT part. It's just this hidden airway problem that I'm trying to bring to your attention.
That is great. And I want to thank you, Jennifer, for this wonderful talk, wonderful information. And thank you all for tuning in to APTA Orthopedics Podcast. We hope you found today's episode informative. Remember to subscribe. And until next time, stay ahead in orthopedic physical therapy.